Okay guys, the topic that we shall study this time would be by the name of tension pneumothorax, which is an example of type 2 respiratory failure. So let's look at the manifestations for type 2 respiratory failure that will be developing in a patient. For this particular topic, you need to primarily remember the fact that there could be a breach in the chest wall, like a bullet injury to the chest, that can contribute to tension pneumothorax. This is the representation of the lung and the pleural space. The intrapleural space is about having a pressure of -2 millimeter of mercury. On taking a deep breath on an inspiration, you will notice the fact that the pressure will become -6 millimeter of mercury. So the normal intrapleural pressure at the end of a routine inspiration is -2 millimeter. But if you take a deep inspiration, then it will become -6 millimeter of mercury. So the pressure in the pleural cavity is always negative. The pressure in the atmosphere outside is at positive pressure of 760 millimeter of mercury. Now, if there is a breach of the chest wall, for example, this guy gets a bullet injury to the chest, then you will notice the fact that air at high pressure will be entering into the chest of the patient. This air that enters into the chest at a high pressure will result in development or collapse of this entire lung. So I will just remodify the diagram by saying that because there is air entering into the chest of this patient, this will result in creation of a tissue flap. Mostly the tissue flap that is created will be function like a one-way valve. What I imply by one-way valve is that air will be rushing into the chest but will not be able to come out. So there will be a collapse of the entire lung of the patient. I have now shown the lung like deflated like a punctured balloon, and there will be air at positive pressure in the pleural cavity of the patient. If you look at this representation, you can see the fact that in tension pneumothorax, since the pressure in the intrapleural space is turning out from negative to positive, this will cause a complete collapse of the lung. This will also push the heart of this patient to the contralateral side. The heart of the patient will also be displaced to the contralateral side. There would be air around the heart of this patient as well, and this will also contribute to a tracheal shift. There would be a contralateral tracheal shift in the patient, and the patient will be operating on a single lung. Therefore, while I'm describing this particular condition to you, I would like to just pay regards to one of our brave soldiers. His name is Chetan Cheetah. This guy whose name I'll just quickly mention before you. Chetan Cheetah, this was 2017 Holi, when we were celebrating the Holi festival. This guy, he was a commanding officer of a unit which was fighting terrorists in Jammu and Kashmir in Srinagar. And this guy, the name itself is so brave, Chetan Cheetah. This guy, he took a direct bullet injury to the chest from the terrorists. So because of the fact that this guy had developed tension pneumothorax, he would have died in the battlefield right in the streets of Srinagar. But luckily there was a doctor available that particular day on that particular encounter site, and this doctor played a heroic role with respect to saving this guy's life. So we will just talk about how tension pneumothorax will unfold and what are the steps to be taken by any physician or any doctor who happens to be there when tension pneumothorax is developing in a soldier. And you can just Google this word Chetan Cheetah. You'll find amazing reviews about this brave man who fought for our country, and he was fighting terrorists in Jammu and Kashmir when he received multiple bullet injuries to the chest. He survived to tell the story. You can listen to his videos on YouTube. But at the moment, let's focus on what's going to happen in this patient, or what happened to this fellow immediately after he took a bullet injury to the chest. The first thing that would have happened would be that in this guy, because there is pressure which is positive in the chest, therefore the positive pressure in the chest will result in development of kinking of the great veins. There would be kinking of the great veins in the chest, like the superior vena cava and the inferior vena cava. You see, the pressure in the veins is less than the atmospheric pressure. So because there is kinking of the great veins in the SVC, superior vena cava, and IVC, inferior vena cava, therefore in this patient the venous return will almost decrease to 0. And if the venous return to the right side of the heart of the patient will become almost 0, the blood pressure of the patient will also fall. So you need to remember the fact that when it comes to the topic of tension pneumothorax, there is a unrecordable BP developing in a patient, and this is known as obstructive shock. You see, they've asked this question in the exam that which of the following is a cause of obstructive shock, and lots of guys could not answer the question. The cause of obstructive shock is tension pneumothorax. I'll mention 3 causes of obstructive shock before you. One I have discussed in the cardiology section, cardiac tamponade. Second cause is being discussed right now, that is tension pneumothorax. And the third cause, you can find this in the liver section of the video series, that would be Budd-Chiari syndrome. Budd-Chiari syndrome will be having thrombosis of the hepatic veins and the inferior vena cava, because the blood supply to the IVC will be severely compromised in Budd-Chiari syndrome. Therefore, venous return to the right side of the heart is again compromised, and that will explain obstructive shock. Coming back to the topic, in tension pneumothorax, because the BP will become almost unrecordable because of the kinking of the great veins, therefore objective or discussion is what will you do for management of tension pneumothorax to convert the blood pressure from unrecordable to recordable. If you attempt MCQs of the AIIMS exam, I would say of the previous 4 exams, that is 4 consecutive years, 8 papers, every year there has been a question on management of tension pneumothorax in one way or the other. So let's look at how would you convert the blood pressure from unrecordable to recordable in this particular patient. Examination findings in tension pneumothorax. The doctor who would have been attending to this brave soldier would have found the following findings, which are as follows. When he would have evaluated this patient, he would have noticed that the trachea of the patient would not be in the middle in the suprasternal notch. The trachea would have been shifted to the contralateral side, that is, one-sided shift of the trachea would be present. Apart from the tracheal shift in this guy, you will also notice that there would be presence of apex beat being deviated from its original position. So normally the apex beat is always in the 5th intercostal space, 2 cm medial to the mid-clavicular line. But in this case, the apex beat will be shifted, and this apex beat displacement will be rather to the contralateral side. That is, like the bullet went into the right side, then the apex beat will be pushed further towards left. Then in this patient, the percussion note on that particular side of the chest where there's a tension pneumothorax will become hyperresonant. Though it might not be feasible to check for percussion on the side where there's a bullet injury because the soldier is in great distress, but this is definitely a finding to be remembered, percussion out of hyperresonance. Then when the doctor who's attending this case would have auscultated this guy, that is, when he would have put his stethoscope over the heart of the patient, auscultated him over the heart, he would have heard on auscultation over the heart of this patient a very characteristic finding, and this characteristic finding that is found in patients of tension pneumothorax because there is air around the heart is known as Hammond-Crunch sign. This is definitely a MCQ statement that I'm speaking. Hammond-Crunch sign. This is a auscultatory finding of pneumomediastinum. Because there is air around the heart, so the auscultatory finding that I'm discussing is known as Hammond-Crunch sign. Well, how does it sound? This is like somebody is walking on snow, freshly fallen snow, with leather boots on. So when and the leather boots would be like military grade heavy duty leather boots. So somebody is walking with leather boots on. That's the kind of sound that you will get in Hammond-Crunch sign. The word is crunch, like somebody is walking on snow with heavy duty military grade leather boots on. So do remember this MCQ statement. Hammond-Crunch sign is diagnostic of pneumomediastinum. That's very characteristic feature. And the next finding that would have been seen in this soldier would have been with respect to auscultation over this area, that is where he got the bullet injury. So if you auscultate him here, that is over the lung area of the patient, then the objective would be to listen for air entry and breath sounds. Now in patients who are suffering from pneumothorax, when you auscultate the patient for air entry and breath sounds, you will notice the fact that the air entry in the patient will be absent because there is no lung, so air entry would be absent. And the breath sounds of the patient will also be absent. So when you read this data that air entry is also absent and breath sounds is also absent, that is a diagnostic of pneumothorax in a patient. Absent air entry and absent breath sounds is diagnostic of pneumothorax in a patient. The type of pneumothorax that we're talking about here is obviously tension pneumothorax. The word tension is to highlight the change in the pressure in the pleural cavity and it is affecting the mediastinal cavity as well. So well, for management of the soldier, there is no time for doing an X-ray in the battlefield. So immediate management is required, and which is that you will use a lumbar puncture needle. This lumbar puncture needle will be inserted by you in the second intercostal space of the soldier. You will not insert this needle in the parasternal line because the heart is displaced. So you will put it on the side of the bullet injury in the midclavicular line. When you put the LP needle into the chest of this patient, you will then withdraw the stellate once the needle is in the pleural cavity, and you will hear a hissing sound from the back of the needle. The sound would be like somebody, like the whistling sound that you see over a pressure cooker when the food is being cooked. So the hissing sound is because the air is escaping from the back of the lumbar puncture needle. After that, you will attach a 3-way stopcock to the backside of the lumbar puncture needle, because I don't want air to go into the chest by the LP needle. Air will obviously be escaping out of the pleural cavity of this patient. The advantage of allowing this escape of air is because of the fact that air is going in the chest due to pressure difference, and there is a one-way tissue flap that is created that will allow air to go into the chest cavity, not come out. So you have created an exit mechanism for air. The lumbar puncture needle has created an exit mechanism for air. So therefore there's a hissing sound and the air will escape, and now when the air will escape, the pressures on the two sides will become equal. So there could be a possibility that again there could be movement of air in and out, and this could be counterproductive. So we will use a 3-way stopcock and close the lumbar puncture needle orifice. Advantage would be that air will continue to go into the chest by the bullet side injury, but when you will again release the stopcock, the air can be decompressed. So you are creating a decompression pathway for the chest of the patient, following which you will be putting a chest tube in this patient in the 5th intercostal space. This intercostal drainage tube, which is put by you in the 5th intercostal space in the mid-axillary line, is always by default put in the mid-axillary line, will be connected to a underwater seal. The advantage of this underwater seal will be that it will generate negative suction, and that negative suction will help in evacuation of both blood and air which will be present in the chest cavity of the patient. So the chest tube is connected to an underwater seal. The negative suction will suck out the air and the blood which is present in the chest cavity. So pneumothorax of the soldier will definitely be managed. Once you have done these two basic tasks in the patient, then he obviously needs to be transported to the nearest hospital where he will be given massive blood transfusion. Normally, the blood group of the soldier is inscribed on the dress of the soldier, but in this case the dress might be burned, so we will have to give O negative blood. In massive blood transfusion, you have to give to the patient 6 units of packed RBC, 6 units of fresh frozen plasma, and 6 units of platelets to the patient. So it is blood components that are given in massive blood transfusion. So older definitions of massive blood transfusion were like giving to the patient 5 liters of blood over a 24-hour period, but now we talk about blood components which are given in ratio of 1:1:1, massive blood transfusion. Following massive blood transfusion, our surgical team will take over the case from you. They will perform an emergency thoracotomy and they will be operating on the patient in a sense that they will be achieving hemostasis. They will also be removing the damaged part of the lung, that is lobectomy or pneumonectomy, and they will also be going in for bullet retrieval. So our objective is here to highlight the fact that what will you do immediately to raise the blood pressure of the patient, and that is not gonna be any IV fluid administration to the patient. It is lumbar puncture needle that has to be put in the second intercostal space to deflate or reduce the pressure, and thereby the venous return to the heart will improve, the BP will pick up. Second step is intercostal drainage tube, and then the surgical team will take over the case from you. So mostly in the MCQs they have asked regarding immediate management for this condition, that is a LP needle. The description that I have given for you is for topic of what is known as tension pneumothorax. Two important findings which I want you to remember for today is one, Hammer-Crunch sign, pneumomediastinum, that's an important one. And the second situation which I want you to remember from this discussion is absent air entry and absent breath sounds. That is an auscultatory finding that is seen with respect to pneumothorax. So two data to be remembered for today, that is absent entry, absent breath sounds, pneumothorax, and Hammer-Crunch sign for pneumomediastinum. When it comes to the mortality rates, fairly high in this patient because the BP of the patient becomes unrecordable, and this happens to be an example of obstructive shock. Now compare this with another patient. This patient of mine is a big time smoker, He has been smoking on cigarettes for as long as he can remember, and this is the damaged lung in this patient. This is a patient of emphysema. The lung of this guy even does not resemble a lung. It's just these big cystic dilatations on the surface of the lung, and these big cystic dilatations can rupture anytime. So if these big cystic dilatations will rupture, then there will be escape of air from the lung into the pleural cavity, and again the pressure in the pleural cavity will begin to change, because normally the pressure in pleural cavity is negative. So in emphysema there can be a rupture of the bulla, and the rupture of the bulla can result in escape of air into the pleural cavity. Such a kind of a situation where there is a bulla rupture and there is escape of air from the lung parenchyma into the pleural cavity, causing a change of pressure in the pleural cavity, is known as tension, is known as spontaneous pneumothorax. So I have today tried to explain to you two types of pneumothorax, tension and spontaneous. In spontaneous there is no breach of the chest wall, but it is simply the rupture of the bulla which has resulted in accumulation of air in the pleural cavity at positive pressure. So let us see what are we gonna do for this particular case. Just making the discussion clinical. In these patients, let me say this question will describe a 60-year-old guy. He is a big time smoker, smokes on 2 packets of cigarette every day, and even you can smell the nicotine on the clothes of this patient. So this 60-year-old cigarette smoker, he was watching a cricket match and his favorite player, let me say it's Virat Kohli, he got out, and following that he was smoking another cigarette because he's stressed out and he had a coughing bout. You see, cigarette smokers need a reason to smoke. This guy's favorite player got out for a zero, got clean bowled out in a cricket match. So this guy was pretty angry about it. He was cursing that his favorite cricketer, as we Indians are very, I would say, passionate about cricket. So this guy had a coughing bout, after which he suddenly turned blue. So his family members gave you the history that my father is a big time cricket fan and he's always smoking on a cigarette also. And today while watching a cricket match, he was coughing vigorously and then he suddenly turned blue, and he could not even speak properly. His lips was all blue. He was having very fast breathing. Respiratory distress came in. It was everything very sudden, and in a flash, doctor, we could not understand anything, and therefore we decided to rush him to the hospital. Luckily your hospital was nearby, so you were attending to this old man who suddenly turned blue, lips turned blue, and there was respiratory distress. There can also be possibility that he was eating his food simultaneously. So initially they thought that maybe he swallowed something, something went into his trachea, and that is why he had all these complaints. But that can cause you to be under impression that there could be a risk of aspiration in this guy. So let us see what will you do to evaluate this person. On examination in these patients, you will notice the respiratory rate of this patient is increased, something like 30 per minute. Normally is 10 to 16 times per minute. Accessory muscles of respiration like sternocleidomastoid, scalenus anterior, and then alveoli are working overtime. So because in this guy the muscles of respiration are working overtime, the accessory muscles, it tells you that there is definitely a respiratory event occurring. So in this patient you checked for the position of the trachea, and you found that the trachea of the patient was having a one-sided displacement, a contralateral displacement. Like for example, if the pneumothorax is gonna be left-sided, the trachea would be shifted to the contralateral side. Let's take it practically. Maybe in the casualty you are not being able to appreciate the tracheal shift. You would still be able to appreciate the fact that in this particular case, when you do percussion over the chest of the patient, there would be a hyper-resonant percussion note. Now, assuming the fact that in your casualty there's a lot of noise and cacophony, and you are not able to evaluate the percussion note of this patient, which is hyper-resonant, one finding that will be unmistakable for this particular fellow would be an auscultatory finding. Because when you are gonna auscultate over the lungs of the patient, there would be an absent air entry on that particular side, and you will also notice absent breath sounds. So I'm not saying silent chest, but I'm definitely highlighting the fact that on one side you will definitely be hearing labored breathing, but on the contralateral side you might hear conducted sounds, but you will not hear breath sounds in the patient. You would not have air entry on that particular side, and therefore in this fellow you need to do a priority chest x-ray. When you do the x-ray in this person, you will notice the fact that in this guy, on performance of the x-ray, one, there could be shift of the position of the heart. Now in some cases it is difficult to actually check for the shift of the heart position because it's a AP view. So let's look at what other findings will you see. Please give me undivided attention for the next few minutes so that I can just get my point across. I'm describing normal and then I'll describe abnormal. Listen to the normal. In a normal person, in the X-ray, you can see blood vessels in the pericardiac area, and then what happens is that the blood vessels exhibit a tapering, and in all of us, as we go to the periphery, there are hardly any blood vessels seen. So if I divide the X-ray of a normal person, this is normal, I can say that maximum vascular shadows are seen in the most medial part of this discussion. The blood vessels become very thin in the medial part of this vertical divisions of the lung, and in zone 3, which I'm pointing here, that is the most peripheral zone, in you and me hardly any blood vessels are seen. So in the lung of a normal person, maximum vascular shadows, that is whiteness, is seen in pericardiac area. Then there's a pruning, and in zone 3 there are no blood vessels. Now in pneumothorax patients, what will happen will be that in that area where there's a pneumothorax, in a patient, you will notice that the lung of the patient will appear more black than normal. You will also notice that the vascular shadows which are traditionally present pericardiac will be totally absent in the patient, because there is no lung, there is no vascular shadows that can be seen in the patient. Plus you will also be able to notice another finding, which is that in this patient, on this particular side where there's a pneumothorax, the CP angle of the patient will look very prominent. This would be called as a deep sulcus sign. So in patients who are suffering from tension pneumothorax, you will always be able to delineate or explain or see in the X-ray a deep sulcus sign, absent vascular shadows, and the lung appearing black. And then you will also be able to see a pleural reflection. This that I mentioned before you is the pleural reflection, because above this is normal lung, but below this there is no lung tissue because the lung has simply deflated due to rupture of the bulla. So superiorly you might see vascular shadows. I can just represent a couple of vascular shadows here. You can see vascular shadows in the upper part medially, but then obviously as normally they would be pruning in the periphery part, and then in the lateral part no blood vessels. So this image, this X-ray basically shows presence of 3 findings on pneumothorax. Blackness in the lung is exaggerated. Now you can argue that blackness of lung is exaggerated even in emphysema, but in emphysema you get a finding which is flattening of the dome of the diaphragm, and here I have not shown any flattening of the dome of the diaphragm. Then in emphysema vascular shadows can be appreciated, but here vascular shadows cannot be appreciated at all, and there's a deep sulcus sign in a patient. So these are radiological findings for diagnosis of pneumothorax, and once you have identified pneumothorax in a patient, then subsequently it is time for treatment. Now for treatment of patients of spontaneous pneumothorax, the answer will depend upon how much percentage of lung has collapsed. If less than 25% of the lung has collapsed in the patient, then you will have to give supplemental oxygen to the patient, and you can give the supplemental oxygen with help of nasal cannula. But if you notice that there is 25 to 50% lung collapse, lung collapse in a patient, then you don't need to give any supplemental oxygen to the patient, but the primary management will be that you will have to use a syringe and a needle. Like you can use a 50 ml syringe and a needle, and you will have to use and aspirate the air out of the pleural cavity, out of the chest cavity, pleural cavity of the patient. This needle aspiration is different from the concept of putting a lumbar puncture needle in the chest of the patient. Lot of guys read this casually and think them to be the same, whereas that is not the case. Here you are using a traditional needle, putting it in the chest. Obviously you need to use a longer needle than the standard hypodermic needle, and aspirating air using a 50 ml syringe from the chest of the patient, which has accumulated in the pleural cavity due to rupture of the bulla. Now if you find a question that mentions more than 50% of the lung collapse, or for that matter of fact the question says the fact that the patient is having central cyanosis, mind my words here, central cyanosis present, if central cyanosis is present, then irrespective of the percentage of lung collapse, you are supposed to manage the case. If there is more than 50% lung collapse or central cyanosis in a patient, then for management of this particular patient you will have to put in a chest tube. Like in my case, the old man turned blue. I said that right away, that he was watching a cricket match, the lips turned blue, so I have to put a chest tube in this patient, which will be put by me by default in the 5th intercostal space. This would be put in the mid axillary line of the patient, and this will help in removal of the air at positive pressure in the chest of the patient, because this is hooked up to a bag which is known as an underwater seal. It will generate negative suction, and this will help in removal of air in the chest cavity of the patient. So remember the fact that for a pneumothorax of the spontaneous variety, if you mention central cyanosis, then chest tube is the logical answer. Most of the time the MCQs on spontaneous pneumothorax have been given with respect to rupture of the bulla in the lung. However, recently there was a question on spontaneous pneumothorax with respect to pediatrics. In pediatrics, the concept was that the baby was having a Staph aureus pneumonia, and in Staph aureus pneumonia, you are all aware that there could be formation of this radiological finding on pneumatocoel, which is a cavity which is filled with air. Now, if there is a pneumatocoel rupture, then this cavity will communicate with the pleural space, and in pneumatocoel will communicate with pleural space. That means lung parenchyma is communicating with pleural space. So once again, the pressure air of the lung parenchyma will come in the pleural cavity of the patient and will result in a spontaneous pneumothorax to develop in a patient. In tension pneumothorax, there would be history of trauma, but spontaneous pneumothorax, it could be rupture of a bulla or it could be rupture of a pneumatocoel. You see, the questioner described a 6-month-old baby with pneumonia. And the question mentioned that the 6-month-old baby with pneumonia is on vancomycin. So he did not say Staph aureus, but he said 6-month-old baby with pneumonia is on vancomycin for past 2 days. The question also mentioned that the child was improving and responding to treatment, and the mother had given a feed to the baby half an hour back. So the child is taking feeds. You can understand, if a child who's admitted in the hospital is taking feeds, it means the fact that he is pretty stabilized and he is responding to treatment, and maybe the pediatrician would have told the parents that we'll discharge your child after 2-3 days on oral medication. Now they mentioned that the child suddenly turned blue, sudden onset cyanosis and respiratory distress developed in the child, and the mother really panicked and freaked out, and she called the doctor and she said, please sir, have a look, suddenly my baby has turned blue. He was responding to your treatment. He had started taking feeds also. I fed him about 1 hour back, and now suddenly there's a cyanosis with distress. So initially you might get the impression that he might have had a hypoxic seizure. You might think that this child is having a convulsion due to any etiology which you would like to work up, but then there is no history of any violent jerking of the body. There is no seizure disorder present in this child, and therefore you ordered a quick x-ray, and the image that was given in the x-ray was showing that characteristic deep ulcer sign that I mentioned before you. The question did not ask the diagnosis. Diagnosis is very straightforward, that is pneumothorax. You see deep ulcer sign, you to know it as pneumothorax. The question said, why did this happen? So I'm not going into 4 choices of the MCQ, but I'm trying to explain to you that do not be under impression that there would always be a question that will mention regarding a emphysematous patient and rupture of a bulla. There could be a question talking about a pneumatocoel rupture which could result in development of a spontaneous pneumothorax in a patient. So today I have given you 2 causes of spontaneous pneumothorax, bulla rupture as well as a pediatric cause of pneumatocoel rupture. Just to wind off this topic, spontaneous pneumothorax, remember, do not think that needle aspiration and LP needle is one and the same thing. Needle aspiration is hooked up to a 50 ml syringe to aspirate air out of the chest cavity of the patient. For the topic of SP, that is spontaneous pneumothorax, remember, one of the leading causes could be, the question could describe emphysema. How will you say emphysema? Tall, thin smoker with sudden onset distress. Then in some questions he might mention tall, thin individual with arm span more than the height. Then might say that this patient with marfanoid appearance, arm span more than height. Might even say that this person with marfanoid appearance is having a lens dislocation or is having a mitral valve prolapse. So what I'm trying to say is that people with Marfan syndrome are also predisposed to development of spontaneous pneumothorax in a patient. Or he might mention regarding rubberman syndrome, who's a very flexible person. Rubberman. These patients we call the third rubberman because they are highly flexible and they can contort their body into let me say a small container. They might be appearing on Guinness Book of World Records. And then you could have a pediatric cause of pneumatocoel rupture which could have resulted in development of spontaneous pneumothorax in a patient. So these are 4 causes of spontaneous pneumothorax. Any of these situations can be given to you with the chest x-ray. That would help you in identification of the damage which is present in the lungs of the patient. Management protocol I've told you depends on the percentage of lung collapse.